Welcome back, ladies and gentlemen. We now proceed to our third plenary on optic neuritis and the evolving seromarker enigma, presented by Professor Chen. I cordially invite Dr. Chulika Makavita and Dr. Dunyaluk to introduce our esteemed speaker.
It's my pleasure to introduce Prof. Chen. Professor Chen is a professor of ophthalmology and neurology in Mayo Clinic, USA. Prof. Chen attended the University of Virginia for his undergraduate and combined MD PhD degrees and completed his ophthalmology residency and neuro-ophthalmology fellowship training at the University of Iowa. He then took a position at the Mayo Clinic in 2014, where he specialized in neuro-ophthalmology. Currently, he serves as a consultant and professor of ophthalmology and neurology. And he is the Neuro-Ophthalmology Fellowship Director at the Mayo Clinic. Among Prof. Chen's awards and honors are the AAO Senior Achievement Award, Top Doctors in Minnesota, the HEED Fellowship, Real World Ophthalmology Inspiring Academic Leader Award, Ophthalmology Teacher of the Year Award 4 times, leading to introduction of the Educators Hall of Fame, and the Mayo Clinic Distinguished Educator Award, awarded to the top educator at Mayo Clinic in Rochester. He has published over 250 peer-reviewed manuscripts, and his research interests include ophthalmologic imaging, idiopathic intracranial hypertension, and optic neuritis, especially NMOSD and MOG antibody-associated disease. I would now kindly invite you for your talk on optic neuritis and the evolving seromarker enigma. Over to you, sir.
Well, thank you so much for that kind introduction and the invitation to speak here today, this evening. Again, we're going to talk about optic neuritis and the evolving seromarkers. This group knows that optic neuritis is an inflammation of the optic nerve. It's the most common cause of optic neuropathy in young patients. Classically, patients present with subacute monocular vision loss, and with optic neuritis, 90% will have eye pain, especially worse with eye movements, and that can help differentiate optic neuritis from other optic neuropathies, like ischemic optic neuropathy, which will be painless. When we look at the optic nerve in the setting of optic neuritis, 2/3 of the time, the optic nerve is actually normal. There's not optic disc edema. And 1/3 of the time, you'll see some disc edema, but typically it tends to be on the more mild end, similar to this fundus photograph here. And an MRI will typically see enhancement of the optic nerve to help confirm that's an optic neuritis attack. After optic neuritis, fortunately, the majority of patients improve over 1 to 3 months, with 92% of patients improving at 20/40 or better. But 3% of patients overall can end up 20/200 or worse or legally blind. So not every patient recovers. And a lot of that depends on the etiology, the cause of the optic neuritis. And so this group knows that the 3 main causes of optic neuritis that we know are multiple sclerosis, NMO, where our biomarkers, the antibody against OCT4, and MOGAD with the antibodies against MOG. We did a population-based study at the Mayo Clinic using the Rochester Epidemiology Project. And you can see here in an area that's predominantly white, MS makes up over 50% of optic neuritis. Almost 1/3 is still idiopathic, 5% were MOGAD, 3% were OCT4 positive NMOSD. I know Dr. Pittock, Dr. Flanagan, and our colleagues here at the Mayo Clinic have been collaborating quite extensively with Sri Lanka. And essentially, you can see here that this was a talk by Dr. Senanayake. And you can see here that the distribution is a little bit different in Sri Lanka, where MS only makes up 13% of optic neuritis. NMO makes up 5%. MOGAD actually makes up 18%. It's actually the most common known cause of optic neuritis there in Sri Lanka. So what I'd like to do is now talk a little bit about MS. I know there are no serologic biomarkers for MS, but we do have OCT as a biomarker for optic neuritis in MS, which is important now. I also wanted to bring up MS because this is at least what we think about in the US as our typical prototype optic neuritis. Because again, it's the most common cause of optic neuritis in the US. It's typically can be a young adult female. Caucasians affected more than Black and Asians. It's usually unilateral vision unilateral optic neuritis with mild to moderate vision loss. Again, eye pain 90% of the time, typically good recovery, but not always. A third with disc edema, but usually mild, again, similar to this picture here. And of course, with MS, you're going to get these periventricular white matter lesions. Now, I think the biggest update for MS is the 2024 McDonald Diagnostic Criteria, which was actually just published in October of 2025. And what's important, one of the large changes with this revised diagnostic criteria is now optic nerve is the fifth anatomical location to demonstrate dissemination in space. Furthermore, you can actually use OCT and visual evoked potential to actually confirm or diagnose a prior optic neuritis, even if it's subclinical. And this is very important in detecting prior optic neuritis. And a lot of it, again, when it comes to OCT, it's all about the anatomy. What happens after optic neuritis is you get thinning of the retinal nerve fiber and thinning and loss of the ganglion cells. And it's due to essentially anterograde and retrograde degeneration after you have an optic neuritis attack. And we can actually detect that by looking at the retina. So we're going to zoom in here at the retina. And again, what happens is you get thinning of the retinal nerve fiber and the ganglion cell layer. And for many years, the only way you could see these layers is essentially post-mortem, looking at essentially a retina in a dish, and you can see all the layers. But over the past maybe 20 years or so, and the technology keeps getting better, we now have OCT or optical coherence tomography, where we're actually able to see every single one of these layers of the retina that you can see post-mortem. And essentially, this is actually an OCT image of my own eye, taken undilated. And you can see here, here's the optic nerve. This is the macula. This is the fovea. And the layers that we care about when it comes to optic neuritis is the retinal nerve fiber, which are the axons that give rise to the optic nerve, and the ganglion cell layer, which are the ganglion cells that give rise to the optic nerve. And again, after a bout of optic neuritis, you actually get thinning of both of these layers. And so here's just an example of a patient with acute optic neuritis in the right eye. They're 20/60. And then 3 months later, 6 months later, you can see that this patient actually recovered to 20/20. But you can see that there's a pretty profound amount of thinning of the retinal nerve fiber and ganglion cell, despite this patient recovering to 20/20. And therefore, OCT is quite capable of picking up prior optic neuritis because it leaves a footprint, even if the patient recovers to 20/20. We did a study at the Mayo Clinic looking at OCT and the sensitivity in detecting prior optic neuritis, and we found that it is 96% sensitive. In fact, I've actually never seen a patient with optic neuritis with vision loss who didn't have a footprint on OCT. The only rare cases where OCT doesn't pick up the optic neuritis is when they only have pain with eye movements, but not vision loss, but you know it's an optic neuritis because you see inflammation on the MRI. Those patients without vision loss won't have the footprint. But if the patient had vision loss with the optic neuritis attack, even if they recovered in 20/20, we see that footprint. There's been a lot of studies looking at the optimal inter-eye difference for picking up prior optic neuritis, because we're all pretty symmetric people in terms of our eyes. So if you've got a RNFL thickness of 90 in one eye and an RNFL thickness of 80 in the other eye, that could indicate that the eye with the 80 actually had a prior optic neuritis attack. And so multiple studies have been trying to determine what is the best threshold in picking up these prior optic neuritis attacks. And ultimately, this has been now published in the McDonald criteria, where essentially, if you have an RNFO difference greater than 6 microns or GC-IPO difference of greater than 4 microns between the two eyes, that could be evidence of prior subclinical optic neuritis. And here's just an example of a patient who was seen in the MS clinic for evaluation of possible DMI disease. The patient had some periventricular white matter lesions. They had a spinal cord lesion, but no history of optic neuritis. And if you look at this OCT, what you can see here is that even though the patient had no history of optic neuritis, the right eye actually is 7 microns thinner in both the GCL and the RNFL. And therefore, this is evidence of subclinical optic neuritis in the right eye, and it can help clinch that diagnosis of MS. And again, this is now part of the diagnostic criteria. And so that's the main update we have for MS. Again, we've known about MS for many, many years. We still don't have a serological biomarker, but we now have OCT as a biomarker for optic neuritis that we can help to clinch the diagnosis. Now we're going to talk about NMO. Again, in Rochester, Minnesota, it makes up 3% of our optic neuritis. In Sri Lanka, 5%, but a very important optic neuritis. We recently looked at the optic neuritis seen at the Mayo Clinic, 244 of them, and looked at their demographics and outcomes. You can see here that 85% were female, so there's actually a stronger female predilection in NMO than in MS. A little bit less eye pain. 24% had optic disc edema, so a little bit less than MS. 20% were bilateral, which again, we don't typically see it in MS. If you see it bilateral optic neuritis, you want to think about NMO or perhaps MOGAD, which we'll talk about in a little bit. And 20% of the time, it can involve the optic chiasm, which MS doesn't typically do. And so these are all features that make you want to think about NMO. And of course, the reason why we care about NMO is the vision loss in terms of optic neuritis. The visual acuity at nadir is count fingers compared to 20/70 for MS. The final median visual acuity was 2200, with 46% of patients ending up 2200 or worse. So the bottom line is NMOSD causes blindness, much more so than MS, and therefore we have to treat these patients very aggressively. With MS, we typically treat with IV corticosteroids. With NMO, we typically do both corticosteroids and plasma exchange. With plasma exchange, essentially we're removing the pathologic antibodies, immune complexes, cytokines, and it's a very important treatment, what we think, for NMOSD, because we know the outcomes are so poor. We recently did a very large international multi-center retrospective analysis of almost 400 optic neuritis attacks. 75 were aquaporin 4 positive NMOSD. And what you can see here is that at the time of PLEX treatment, the median visual acuity was count fingers. So again, we typically PLEX quite severe NMOSD. But then after PLEX, the median visual acuity was 20/30. And we talked about in our full cohort at Mayo Clinic, we think the natural history of the median visual acuity is 2100, and therefore we do think plasma exchange or PLEX leads to better outcomes in NMOSD. We're trying to avoid this natural history of 2100 and get them to 2030, 2020, 2025, essentially better outcomes. And so when patients have NMOSD and they have an acute attack, we're typically treating with IV corticosteroids and plasma exchange pretty much simultaneously, especially if it's a severe attack. And then all patients with NMOSD require long-term immunotherapy, and that's rituximab, enobalizumab, satralizumab, eculizumab, and ravulizumab. These are, except for rituximab, all FDA-approved medications here in the US, and have really made a huge impact in NMOSD in terms of trying to calm disease down. And now we're going to talk about MOG here. And again, in Rochester, it makes up maybe 5 to 6% of optic neuritis in adults for the most part. In children, it actually makes up a much higher proportion. Interestingly, in Sri Lanka, it was actually the most common known cause of optic neuritis, making up 18% of optic neuritis in Sri Lanka. And optic neuritis is the most common phenotype of MOGAD. And optic neuritis with MOGAD is a little bit different than NMOSD, than MS. 50% of the time, it's bilateral simultaneous. So that's even more so than NMOSD, which is 20%, which is significantly more than MS, which is usually around 3%. Around 50% of the time, it's recurrent, and it can be steroid. It can be steroid responsive, but sometimes steroid dependent as well. Another striking feature about MOGAD is they tend to have more disc edema. 80% of MOGAD have visible disc edema, and sometimes it can be quite severe, even with peripapillary hemorrhages. And you compare that to MS and NMOSD, where it's a third or less. We talk about OCT and detecting prior optic neuritis. We actually think that OCT is helpful in the acute setting as well, because OCT can quantify the amount of optic disc edema by measuring the retinal nerve fiber layer thickness. And essentially during acute optic neuritis, especially with MOGAD, you're going to get thickening of the RNFL. And this is just an example of a patient with left optic neuritis from MOGAD. And you can see here that that left eye has an RNFL thickness of 215 microns in the acute attack, compared to a patient with MS optic neuritis in the left eye where it's only 100 microns. We did a fairly large retrospective international study looking at OCT in the setting of acute MOGAD optic neuritis and acute MS optic neuritis. And what you can see here is that on the y-axis, this is the RNFL thickness, and you can see that MOGAD patients have significantly thicker RNFL during the acute attack compared to MS. And using a receiver operating characteristic curve, we found that 118 microns was actually a fairly good cutoff in terms of differentiating MOGAD from MS, which was about 80% accurate in differentiating them. And if we use a higher bar of 175 microns, you can see we're capturing about 50% of our MOGAD, very, very little MS. So if you have a patient with optic neuritis, you can actually get OCT during the acute attack. And if there's thickening, you can actually almost confidently say that this is MOGAD even before the biomarker comes back. We know that the MOG antibody can take 1 to 2 weeks to return. And OCT, within 30 minutes, you can actually say, I think this optic neuritis is from MOGAD. With this realization that MOGAD causes a lot of optic disc edema, OCT is actually now being incorporated into randomized clinical trials as an objective sign that a patient has optic neuritis. So essentially, if they have eye pain, mild blurred vision that doesn't actually meet the criteria for an adjudicated attack. But if you get an OCT and there's more than a 10 micron increase compared to the baseline, we can actually say that that is an adjudicated true optic neuritis attack. So that's being used in randomized clinical trials, but it's also helpful to use in clinic as well. With MOGAD optic neuritis, we also see pretty significant MRI findings. Many times you'll get longitudinal enhancement of the optic nerve, and about 50% of the time you get perineural enhancement, where the inflammation not only extends down the optic nerve, but also into the periorbital fat. And this is a pretty specific feature of MOGAD optic neuritis. And then the vision loss. Again, why we care about optic neuritis is the vision loss. With MOGAD, they present with very severe vision loss, a median visual acuity of 2600, very similar to NMOSD. But fortunately, the recovery is much better. You can see here that the median visual acuity was 20/20, with only 5% of patients ending up 2200 or worse. So the outcomes actually are more similar to MS than NMOSD. But not all patients recover. We did a fairly large multi-center retrospective study of 140 MOGAD optic neuritis attacks to look at essentially their character over time. We found that on average, patients have eye pain for 3 days before the vision starts dropping. Then the vision drops for about 4 days before getting to a nadir of 2600. And then the majority of patients recover in response to steroids. Only 13% of patients ended up worse than 20/40, and again, only 5% ended up 2200 or worse. We actually looked at stratifying it by time to treatment, time to corticosteroids, and we found that in patients treated within 2 days, so very, very early steroids, only 2% of patients ended up 20/40 or worse, compared to patients treated after 2 days, where 17%. And even more strikingly different is those treated within 2 days were 20/60 at the time of this treatment, compared to those treated after 2 days were count fingers. So one of the thoughts in terms of why treating early with steroids and MOGAD leads to better outcomes is we're actually preventing them from getting to a natural nadir. If a patient is going to drop for 4 days down to 2600, and we're catching them here at 2 days where they're 20/60, it's a lot easier to get from 20/60 back to 20/20 than if they're 2600 or count fingers and then have to get back to 20/20. And so we think that early steroids in MOGAD optic neuritis is very, very beneficial. And it's something that we strive to do, especially when they have a diagnosis of MOGAD. If they have a new relapse, we're treating them as soon as possible. And so essentially, these patients with MOGAD, we're going to treat them very early with typically high-dose corticosteroids, IV methylprednisolone, for 5 days. And these patients are often steroid responsive, but sometimes steroid dependent, especially early on. And so sometimes we'll do an oral prednisone taper over maybe about 1 to 2 months. We tend to do a pretty short prednisone taper compared to some others, which we'll sometimes do up to 6 months. But we try to limit that prednisone because of the side effects. We think that early treatments are associated with better outcomes. And if it's severe and there's no recovery to high-dose corticosteroids, that's when we want to consider plasma exchange. When we looked at that study looking at about 400 optic neuritis attacks treated with plasma exchange, that multi-center international study, you can actually see here that patients with MOGAD had significantly better outcomes compared to other etiologies when it comes to outcomes after PLEX. You can see in blue, this is the initial, and so they're all about count fingers, NMO, MOG, MS, and idiopathic. But here you can see that the vast majority of patients with MOGAD recovered back to 2020 with PLEX. So PLEX is certainly an option for these patients if they don't respond, and they tend to respond quite well to PLEX, at least based on retrospective data. Again, much of our data on plasma exchange is retrospective, but it is being used much more commonly now. This was a study we did looking at the use of plasma exchange in the US. And you can see from 2015 to 2020, there's this really large increase in PLEX over the past 5 years, and it continues to increase more and more, again, based on retrospective data. Also based on retrospective data, we are all seeing that earlier treatment is associated with better outcomes. This is essentially PLEX within 7 days. You can see that in green, this is a recovery back to 2020. So 65% of patients are recovering back to 2020 if you give them PLEX within 7 days, compared to only about 22% if you're PLEXing after 28 days. And so PLEX is associated with better outcomes in retrospective studies. The only drawback on these retrospective studies is that essentially we're not sure about the natural history. If you're giving a person PLEX at 7 days, this patient could potentially recover with no treatment at all. Whereas if a patient is still 22 and worse at 1 month, we know that person's already destined to do more poorly. And so even though early PLEX is associated with better outcomes, until you have a randomized clinical trial, we don't know that for sure. And that was the impetus for this PCORI trial, PCORI-funded randomized clinical trial for the treatment of severe transverse myelitis and optic neuritis. We actually have 31 centers in the US where we're going to enroll 200 patients with severe optic neuritis, 182 patients with severe transverse myelitis, and we're going to randomize them to essentially steroids with the potential for rescue plasma exchange if they don't respond, versus early PLEX, so simultaneous steroid and plasma exchange right at the time of clinical presentation. And so this is a very important clinical trial that's just starting to enroll, co-led by the Mayo Clinic and Johns Hopkins. And again, we have 31 sites around the US. So hopefully this will give us more answers in terms of the efficacy of PLEX and the timing of PLEX for severe optic neuritis and transverse myelitis. Now, for the last maybe 8 minutes or so, I wanted to talk about these other antibody-mediated optic neuropathies, CRIM5, GFAP, and IGLON5. We'll start with CRIM5, which is probably the most well-described of these three, but these are all pretty rare entities compared to MS, NMOSD, and MOGAD. So CRIM5 stands for collapsed receptor-mediated protein 5, and it was first identified as a biomarker for perineoplastic disease in 2001. In terms of the neurologic manifestations, it's myelopathy, cranial neuropathies, and basal ganglionitis. And in terms of ocular manifestation, it's been described to cause optic neuritis, vitritis, and retinitis. And this optic neuritis, I want you to think about because it's a little bit different than your demonic optic neuritis. This paper was published in Ophthalmology, where we looked at many of the patients with CRIM5 seen at the Mayo Clinic, and a third of them actually had neuro-ophthalmic manifestations. Median age is 67, and females are more affected than men. And this is just an example of a patient with CRIM5 affecting the eyes. You can see that this patient has bilateral disc edema and papillitis. The view in is so hazy because there's vitritis, and patients can have retinitis as well. In our cohort, the vision ranged between 20/20 to hand motion. It was rare to have isolated optic neuropathy. Most of them had either vitritis or retinitis, but occasionally you could have isolated bilateral optic neuropathy. What's important is no patients had enhancement of the retrobulbar portion of the optic nerve, and therefore it's actually a papillitis. It's inflammation of the optic nerve head, not your typical retrobulbar optic neuritis. Another term you can use is actually prelaminar optic neuritis. If you have enhancement, it's just at the optic nerve head, again, not in the actual retrobulbar portion of the optic nerve. 90% had other neurologic symptoms, predominantly peripheral neuropathy. And almost about a third had cancer, half diagnosed before, half diagnosed after the eye symptoms, with small lung cell carcinoma being the most common. And in terms of the terminology, we can use papillitis, which again is that inflammation of just the optic nerve head, or you can call it prelaminar optic neuritis. But it's important to actually to have the word prelaminar because, again, it's much different than retrobulbar optic neuritis. Essentially, D-myelin disease doesn't cause prelaminar optic neuritis. When you see papillitis or prelaminar optic neuritis, you want to think about CRIM5, GFAP, IGLAN5, or other things like syphilis and other things that can affect just the optic nerve head. So again, these paraneoplastic or autoimmune optic neuropathies, they cause a prelaminar optic neuritis or papillitis, very, very different than your demyelinating optic neuritis. So briefly talk about GFAP now. GFAP is a steroid-responsive meningoencephalomyelitis accompanied by GFAP antibodies in the CSF. These patients can present with confusion, meningeal symptoms, myelopathy, and they often have this characteristic radial perivascular enhancement on the MRI and inflammatory CSF, and many of them have optic disc edema. We reviewed our GFAP patients at the Mayo Clinic, and we found that 50% of them actually had optic disc edema. When they had disc edema, it was always bilateral, median age of 40, 60% were male. And here's just that classic radial perivascular enhancement that we see. It was seen in 90% of our cohort. And here's just an example of how a patient presented. They're 20/20 with both eyes with bilateral disc edema and fairly intact visual fields other than enlarged blind spots. And the vision loss tend to be pretty mild between 20/20 to 20/30. And then after treatment, it essentially left some pallor, but again, the vision was pretty preserved. 30% had some residual visual field defects, but certainly not as severe as, let's say, NMOSD. For the most part, visual acuity was unaffected. Mild vitreous cell was noted in 30%. Mild atrophy was noted in 20%. And only the median opening pressure was only 144. They tend to have elevated white blood cells and protein. And so whenever you have swollen optic nerves and intact vision, you kind of think about papilledema from raised intracranial pressure. That's the most common cause of that. But again, these patients mostly had normal opening pressure. So there's something else causing this swollen optic nerve that isn't from raised pressure. And ultimately, we think it's probably because of GFAP and in terms of how it's involved in the retina-blood barrier. We had one patient where we actually had a fluorescein angiogram, and you can see that there was selective venular involvement. So essentially the veins are involved, not the arteries. And so the disc edema appears to be an inflammatory papillitis. Again, isn't from raised intracranial pressure, but it's more of an inflammatory papillitis. Or you can call it prelaminar optic neuritis. And lastly, just a couple minutes on IGLAN5. And again, I have a question mark here because it's pretty newly described. There's only been 3 cases of optic neuropathy described in the literature so far. But I thought I would just go through a little bit. So IGLAN5 was first identified in 2014, and it can have multiple presentations, including cognitive impairment, sleep disturbance is a big one, gait movement disorders, bulbar dysfunction, and motor neuron disease-like syndrome. And essentially, there have been 2 papers published on this. One at the Mayo Clinic that had 2 papers, 2 patients, and one at in Boston at MGH where they had 1 patient. This is a patient that we saw at the Mayo Clinic where they presented with no light perception in the right eye, 20/25 in the left eye, bilateral disc edema. They did improve somewhat. But again, it's more of a papillitis. There's no enhancement of the optic nerve on MRI. This patient did have thyroid cancer. In terms of the patient seen at MGH Boston, presented with less severe vision loss, but again, bilateral disc edema, 20/50 in the right eye, 20/25 in the left. And this patient was associated with a I think a testicular cancer. So sometimes it can be paraneoplastic, sometimes it's not. So essentially, this is our summary. We've got demodeling optic neuritis, where you're going to have enhancement of the optic nerve, and then these paraneoplastics or autoimmune optic neuropathy, where you won't have enhancement of the optic nerve except for the optic nerve head, because it's papillitis or prelaminar optic neuritis. Again, these are much, much more rare, but certainly something we want to look into when you have a patient who presents with bilateral optic disc edema of unknown explanation. Wanted to thank our collaborators at the Mayo Clinic, especially Dr. Owen Flanagan, who is, I know, there at Sri Lanka, and Dr. Pittock and everyone here at the Mayo Clinic, and our outside collaborators really around the world, including those at Sri Lanka as well. Happy to answer any questions.
The audience is open for questions now.
Professor, can I ask a question? So in anterior optic neuritis and retrobulbar neuritis, would you see the same changes in OCT, or would you expect a different sort of changes in retrobulbar neuritis?
Yeah, so in the acute setting with anterior optic neuritis causing optic disc edema, you're going to have thickening of the RNFL. But then afterwards, you're going to get thinning for both causes. And so I think afterwards, it's probably harder to differentiate them, since any optic neuropathy is going to cause thinning. But certainly during the acute setting, if there's disc edema, you can actually measure it with the RNFL thickening, and you can quantify it that way.
A quick question from me as well. So you talk about TRIM5 and it has papillitis and retinitis. So when we are using the ERG to differentiate, it will be tricky, right? So if you are using the VEP and ERG because of the retinitis, so what do you think about it?
No, absolutely. I think it's helpful though, because there's not many things that will cause a papillitis and a retinitis. So if you see those two together, especially if it's bilateral, CRIM5 has to be very, very high in your differential. You'll still think about things like syphilis, sarcoid, other things that can affect both the retina and the optic nerve. But certainly if you see optic nerve involvement and retina involvement, you're not going to be thinking about your typical demodeling disease. So I think ERG and visual evoked potential can be helpful because they're additive. And again, if you see both, that can definitely lean you toward CRIM5. In terms of trying to determine what is causing more of the vision loss, that gets a little bit more difficult, but I guess you could use electrophysiology to try and help determine that. If the ERG is very profoundly down, then you know most of the vision loss is from the retinitis. If the ERG is relatively preserved, then maybe the vision loss is more from the optic neuropathy.
Thank you so much.
Thank you, Professor, for that very important lecture. And shall we show our appreciation in the usual manner for the Professor?